Welcome. In this video, we'll break down the essential knowledge for trainee psychological well-being practitioner, PWP, interviews, starting with NHS talking therapies. Previously known as IAPT, this service began in 2008 to improve access to psychological treatments for anxiety and depression in England. The focus is on evidence-based therapies, delivered by trained and accredited practitioners. Therapy is tailored to match each patient's needs, with the right intensity and duration to ensure the best outcomes. Regular supervision and outcome monitoring are central, using tools like the PHQ-9 and GAD-7 every session. This approach ensures continuous improvement and transparency, making patient progress an active part of clinical care. NHS talking therapies supported over 670,000 adults experiencing common mental health difficulties last year, a 12% increase from pre-pandemic. Teen outcome monitoring is a key part of NHS talking therapies. Every session, practitioners use validated tools like the PHQ-9 and GAD-7 to track patient progress. This isn't just for reporting, it's a clinical tool. If a patient's scores stay the same or worsen, it's a sign to act, adjust the intervention, discuss in supervision, or check on risk more closely. This session-by-session approach gives a continuous picture of progress, not just a before and after snapshot. It's a proactive way to ensure patients get the right support at the right time, and it helps practitioners improve their skills through regular feedback. NHS talking therapies doesn't just address mental health in isolation. There's a strong focus on supporting patients with long-term health conditions alongside mental health issues. Practitioners complete additional training within 2 years of qualifying to work effectively with these patients. This ensures that care is holistic, addressing both physical and mental health needs. By integrating support for long-term conditions, the service aims to improve overall well-being and recovery rates, recognizing that mental and physical health are deeply connected. Let's look at some key figures. As of February 2026, NHS talking therapies saw 670,000 patients in the previous year, a 12% increase from before the pandemic. In 2024, nearly half, 49.5% of eligible referrals moved to recovery. Over 10,000 new therapists and practitioners have been trained, showing the scale and commitment to improving mental health care. These numbers highlight the growing demand for services and the ongoing efforts to meet the needs of diverse communities across England. Stepped care model is central to NHS talking therapies. It ensures patients receive the least intrusive intervention suitable for their needs. If an intervention isn't effective, patients are stepped up to more intensive care, or stepped down if less support is needed. Step 1 involves primary care, like GPs, who may refer patients or prescribe medication. Step 2 is where PWPs offer guided self-help for mild to moderate symptoms. Step 3 provides high-intensity CBT for more severe cases, and Step 4 involves specialist secondary care for complex or high-risk presentations. This flexible system adapts to each patient's journey. Step 1 is all about early detection and support. In primary care, GPs play a key role. They can refer patients to talking therapies or prescribe medication for mild symptoms. Treatments at this stage might include watchful waiting, self-help resources, or medication. The aim is to identify those who may need psychological support and offer the least intrusive help first. If symptoms persist or worsen, patients can be moved up to more intensive support. Step 2 is where psychological well-being practitioners, PWPs, come in. They deliver guided self-help, mainly for mild to moderate depression and anxiety. The treatment is based on low-intensity CBT, focusing on practical strategies that patients can use in their daily lives. Sessions are structured and brief, helping patients develop skills to manage their symptoms. If a patient's needs are more complex, PWPs are trained to recognize this and refer them to higher-intensity services. Step 3 involves high-intensity CBT, delivered by specially trained therapists. This step is for patients with moderate to severe depression or anxiety. The therapy is more in-depth and often lasts longer than the low-intensity interventions in Step 2. The goal is to address more complex symptoms and provide robust support for those who need it. If patients don't respond to Step 3, they may be referred to even more specialized care. Step 4 is for patients with the highest needs, those at high risk, with complex conditions like psychosis or personality disorders, or who haven't improved with previous steps. Here, the principle of least burden applies. Treatment should be as unrestrictive as possible while still being effective. There's also a self-correction principle, meaning the system should adjust treatment intensity based on ongoing feedback and patient progress. Psychological well-being practitioner, or PWP, is a specialist who delivers brief, structured, evidence-based interventions for mild to moderate anxiety and depression. PWPs work within the NHS's step care model, focusing on low-intensity support like guided self-help and computerized CBT. Their goal is to reach many people early, using tools like the PHQ-9 and GAD-7 to track progress. If a patient's needs are more complex, PWPs can refer them to higher intensity services. The main difference between a PWP and a traditional therapist is the focus on shorter, symptom-focused interventions for less severe presentations. PWPs differ from therapists or counselors mainly in the intensity and structure of their work. PWPs deliver shorter, manual-based interventions for mild to moderate symptoms, focusing on practical strategies and symptom relief. Therapists and counselors, on the other hand, often work with more complex cases over a longer period, exploring underlying causes in greater depth. This distinction ensures that patients receive the right level of support for their needs, with PWPs acting as the first line of intervention in many cases. PWP role is multifaceted, covering clinical, administrative, and professional development tasks. Clinically, PWPs screen and assess patients, deliver individual or group treatments, and conduct outreach. They use semi-structured interviews to determine suitability for treatment and decide whether to step patients up, down, or out of the service. Administratively, PWPs manage large caseloads, keep clear records, and communicate with patients and GPs. They also participate in regular supervision and team discussions. Continued professional development is essential, with reflective essays, role plays, and portfolios required during training. PWPs are responsible for screening, assessment, and delivering treatments, both individually and in groups. They conduct initial assessments to explore the patient's main problem and determine the best course of action. Depending on the outcome, patients may be stepped into service for guided self-help, stepped up to higher intensity therapy, stepped down to their GP, or stepped out to another service. Treatment sessions are typically 30 minutes, with PWPs managing caseloads of 60-100 patients and maintaining around 6 hours of contact time per patient. Administrative work is a big part of the PWP role. PWPs manage large caseloads with quick turnover, often expecting each patient to complete treatment within about 2 months. They conduct risk assessments, monitor recovery statistics, and keep clear, detailed notes for every session. Communication is key. PWPs send letters to patients and GPs, discharge patients when appropriate, and bring cases to weekly supervision for discussion. Effective teamwork ensures patients receive the right support at the right time. WPs are committed to ongoing learning and development. During training, they complete reflective essays, participate in OSCEs and recorded role plays, and build a portfolio documenting their progress. This includes reflective outcomes, supervision logs, and evidence of meeting service standards. Continued professional development ensures that PWPs stay up to date with best practices and continue to improve their skills throughout their careers. Post-qualification CPD course in long-term health conditions additionally. WPs need a strong foundation in common factor skills, which include empathy, warmth, and active listening. These skills are essential during initial assessments and treatment sessions. Demonstrating empathy helps patients feel understood and supported. Accurate summarizing, normalization, and minimal encouragers, like nodding or saying, "I see," show you're engaged. Non-judgmental listening, appropriate tone, and good eye contact all contribute to building trust and rapport with patients. Empathy is more than just a buzzword. It's about making patients feel truly heard. Start with sensory language like, "I can hear how much you've been struggling," or "that sounds difficult for you." These statements validate the patient's experience and help build a therapeutic relationship. It's important to use empathy appropriately, only reflecting difficulty when the patient has expressed it, to avoid making assumptions. Initial assessments are a core part of the PWP role. Using the ABC cycle, practitioners explore effective symptoms, like low mood or fatigue, behaviors such as avoidance or withdrawal, and cognitions, thoughts, and beliefs. The funneling technique helps structure these assessments, starting with general questions and moving to more specific ones. This approach ensures a thorough understanding of the patient's difficulties and guides the next steps in their care. In the funneling technique, 1. General open question could be, "What is the main problem you are here for today?" 2. Specific open question, "Have you noticed a change in your behavior at all?" 3. Specific case-aton, "Have your hobbies been affected by the way you've been feeling?" 4. Closed question, "How many days a week did you use to go to the gym?" Then summarize the information, and if needed, ask another specific question before starting a new funnel. Use a separate funnel for each part of the ABC model. Understanding the impact of mental health symptoms is crucial. During assessments, PWPs ask about how symptoms affect work or education, hobbies, close and social relationships, and home management. This holistic view helps practitioners tailor interventions to each patient's unique situation, ensuring that treatment addresses the areas of life most affected by their difficulties. Risk assessment is a vital part of every PWP's work. Practitioners assess current and past suicide risk, self-harm, and other risks like harm from or to others, self-neglect, and risk to dependence. They use intent scales, provide helpline numbers, and develop safety plans for those at moderate risk. Managing risk involves balancing confidentiality with the need to keep patients safe, discussing concerns with supervisors, and taking appropriate action if someone is in immediate danger. If a patient is at immediate risk and cannot keep themselves safe, confidentiality can be broken to contact emergency services or a next of kin. For less immediate risk, the local crisis team or secondary care services may be involved. PWPs must be vigilant, reviewing risk at every session and ensuring there's a clear plan in place. This proactive approach helps protect patients and supports their recovery. Depression is a mood disorder marked by persistent low mood or loss of interest, lasting at least 2 weeks and causing significant impairment. Core symptoms include low mood and anhedonia, with additional symptoms like fatigue, poor concentration, guilt, appetite or weight changes, sleep disturbance, and suicidal thoughts. PWPs use the PHQ-9 to assess depression, ensuring that treatment is tailored to the patient's specific symptoms and needs. Generalized anxiety disorder, GAD, involves excessive, uncontrollable worry about everyday events, lasting at least 6 months and causing significant distress. Symptoms include restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep problems, along with physical symptoms like a racing heart or dizziness. The GAD-7 is used for assessment, helping PWPs identify and address the specific challenges faced by each patient. WPs also work with a range of other anxiety disorders, including social anxiety, health anxiety, panic attacks, phobias, agoraphobia, OCD, and PTSD. Each condition has its own unique features and treatment approaches, but all benefit from evidence-based interventions and careful assessment. Understanding the differences between these disorders is key to providing effective support. Behavioral approach in CBT focuses on how unhelpful behaviors, like avoidance, are learned and maintained. By understanding the relationship between triggers, behaviors, and consequences, patients can learn to change their patterns. Techniques like exposure and behavioral activation help break the cycle of avoidance and withdrawal, encouraging patients to face challenges and re-engage with life. Behavioral interventions are concrete and structured, making progress easy to track. Cognitive approach in CBT teaches that it's not events themselves that cause distress, but our thoughts and beliefs about them. Automatic thoughts and cognitive distortions, like catastrophizing or black and white thinking, can fuel anxiety and depression. Cognitive restructuring helps patients identify, challenge, and replace unhelpful thoughts with more balanced alternatives. This approach targets the root causes of distress, giving patients tools they can use long after therapy ends. BT sees thoughts, feelings, physical sensations, and behaviors as interconnected in a maintenance cycle. Each part influences the others. Negative thoughts trigger difficult feelings, which drive unhelpful behaviors, reinforcing the original thoughts. By addressing both behavior and cognition, CBT treats the whole cycle, not just one part. This whole-person approach is evidence-based and effective for a wide range of mental health problems. Guided self-help, GSH, is a core low-intensity CBT intervention. Patients work through structured sessions focused on understanding and applying CBT strategies to their specific difficulties. Success depends on commitment, attending sessions, setting goals, and practicing techniques between meetings. PWPs support patients with self-help materials, helping them build skills to manage their symptoms independently. Computerized CBT, or CCBT, delivers CBT principles through digital modules that patients complete independently. PWPs introduce and explain the program, provide brief support sessions, and monitor progress. Platforms like SilverCloud and Beating the Blues make therapy more accessible and flexible, though engagement can be a challenge. CCBT is best for mild to moderate cases and isn't suitable for everyone, especially those who need more relational support. WPs use specific techniques tailored to different disorders. For depression, behavioral activation and cognitive restructuring are key. For GAD, worry management and problem solving are used. Phobias and agoraphobia benefit from graded exposure, while panic disorder is addressed with panic management and diaries. These targeted interventions ensure that treatment is relevant and effective for each patient's unique challenges. PWPs don't prescribe medication. They need a working knowledge of common treatments. Antidepressants like SSRIs and SNRIs are used for depression and anxiety, while benzodiazepines, pregabalin, and beta blockers may be used for anxiety. PWPs should know about side effects, such as nausea or increased anxiety with SSRIs, and that antidepressants can take 4-6 weeks to work. If patients have questions about medication, PWPs direct them to their GP or prescriber. Supervision is essential for PWPs. It improves outcomes for patients, supports clinicians, and helps with professional development. There are 2 main types: case management supervision, which is one-on-one and focuses on reflecting on cases, and clinical skills supervision, which is group-based and involves learning from peers. Regular supervision ensures that PWPs continue to grow and provide high-quality care. Diversity means recognizing and valuing differences: race, ethnicity, gender, age, disability, sexual orientation, religion, socioeconomic background, and neurodiversity. It's about respecting these differences in how we work and treat patients. The NHS Constitution values respect, dignity, compassion, and equality. The Equality Act 2010 and Human Rights Act 1998 provide a legal framework for promoting diversity and preventing discrimination. Diversity in the workplace leads to better patient care and outcomes. A diverse workforce reflects the population it serves, improving communication, trust, and treatment adherence, especially for minority or underserved groups. Different perspectives lead to better decision-making and creative solutions. Diversity also builds trust with the community, reduces inequality, and improves staff well-being. Legally, the NHS must promote equality and prevent discrimination. Diverse populations access NHS talking therapies less and have lower recovery rates. Inequality is persistent, with lower recovery among disabled, ethnic minority, LGBT, or low socioeconomic status patients. Improving outcomes means recruiting culturally competent staff, enhancing resources, and adapting therapy to cultural needs. Addressing barriers like stigma, mistrust, and language is essential for closing the access and recovery gap. Personal experience with diversity is valuable. For example, conducting research on ethnic differences in help-seeking, working as a trainee ABA therapist and SEN playworker, and serving as a senior rep for psychology all build understanding of the barriers different groups face. Involvement in EDI committees deepens awareness of how diversity intersects with current events, identity, and lived experience. These experiences inform a more inclusive, person-centered approach to therapy. Culturally sensitive assessment means not assuming a Western, individualistic view of distress. Some patients may express distress physically or understand mental health through family or religious frameworks. PWPs adapt their questions and formulations, using evidence-based approaches, but tailoring them to each patient's background. Building trust and psychological safety early is key, especially for those who may face stigma or mistrust. Hertfordshire NHS Trust, HPFD, Talking Therapies supports around 40,000 adults each year, with a staff of 300. It's one of the top performers in the East of England, exceeding national recovery targets over 50% and achieving high patient satisfaction. HPFD serves a diverse population across Hertfordshire, Buckinghamshire, Norfolk, and Essex, reflecting a wide range of backgrounds and needs. HPFD's values are welcoming, kind, positive, respectful, and professional. These values shape every interaction, ensuring patients feel valued, cared for, supported, listened to, and safe. The mission is to empower people to manage their mental and physical health, keep them safe from harm, and provide the best possible experience. The vision is to deliver great care and achieve great outcomes together by putting people at the heart of everything. Hertfordshire is home to nearly 1.2 million people, with about 1 in 5 from an ethnic minority background. The county has a mix of religions, with the Jewish population being 4 times the national average, and a significant LGBTQ+ community. While generally affluent, there are pockets of high deprivation, with thousands living in poverty or facing homelessness. 96,000 identified as income deprived. Places such as Watford and Stevenage have faster, higher rising unemployment. Understanding this diversity is crucial for delivering effective, equitable mental health care. Roleplay is a key part of PWP interviews. Good roleplay involves gathering information using funneling techniques, showing empathy, and being aware of risk. After the roleplay, you may be asked to reflect on your performance, naming specific skills and acknowledging areas for improvement. Practicing these skills helps you demonstrate your readiness for the PWP role. SDARR technique is a useful framework for answering interview questions. It stands for situation, task, action, result, and reflection. Describe the situation, explain your task, detail what you did, share the outcome, and reflect on what you learned or would do differently. Using SDARR helps structure your answers clearly and shows your ability to learn from experience. Interviews highlight skills like time management, IT proficiency, professionalism, academic ability, and stress management. PWPs juggle large caseloads, use digital systems for notes and scheduling, and must meet deadlines. Stress management is especially important in this high-pressure role, so be ready to discuss how you relax and maintain your well-being. Flexibility and quick thinking are valued in PWPs. You may be asked how you'd handle running late for a group session or other unexpected challenges. Show that you can stay calm, communicate clearly, and adapt your plans to ensure patients still receive quality care. Problem-solving skills are essential for managing the dynamic nature of mental health work. Succeed in your PWP interview. Focus on understanding the stepped care model, the PWP role, core competencies, and the importance of diversity. Practice roleplay, use the SDARR technique, and be ready to discuss your skills and experiences. Remember, being a PWP is about making a real difference in people's lives, so show your passion, empathy, and commitment to high-quality care. Good luck.